Bismillahirrahmanirrahim. So last time we were doing sexually transmitted infections. So the characteristics of ulcerative sexually transmitted infection. The first one is chancroid. Causative agent is Haemophilus ducrei. You do cry with Haemophilus ducrei. Features of primary lesion are multiple and deep ulcers. Base may have gray to yellow exudate. Organism often clump in long parallel strands, which is school of fish appearance. And initial lesion is painful? Yes. Lesion is painful with painful suppurative lymphadenopathy or buboes. Genital herpes. Herpes simplex virus type 1 and 2. Multiple small grouped ulcers. Shallow with erythematous base. Multinucleated giant cells and intranuclear inclusion cowdery type A bodies, and yes, the lesions are painful. Granuloma inguinale, that is donovenosis. It is caused by Klebsiella granulomatis. Extensive and progressive ulcerative lesions without lymphadenopathy. Base may have granulation like tissue. Deeply staining gram-negative intracytoplasmic cysts, that is Donovan bodies, and the lesion is not painful. Syphilis. The painless ulcer or painless chancre is characteristic of syphilis. Painless lymphadenopathy will be seen in stage 1. So non-tender lymphadenopathy. It is caused by Treponema pallidum. Single indurated well circumscribed ulcer, clean base, thin, delicate corkscrew shaped organism on dark field microscopy, and the lesion is not painful. Lymphogranuloma venereum, chlamydia trachomatis causes this, and small and shallow ulcers, large painful coalesced inguinal lymph nodes or buboes, intracytoplasmic chlamydial inclusion bodies in the epithelial cells and leukocytes, and no, the lesions are not painful. Trichomonas vaginalis, punctate ulcers, punctate hemorrhages with strawberry cervix, and there will be no lymphadenopathy. Infectious genital lesions, genital ulcers. The painful ones are herpes simplex virus and Haemophilus ducrei. So herpes simplex virus, small vesicles or ulcers on erythematous base, and mild lymphadenopathy will be present. Haemophilus ducrei or chancroid, there will be large deep ulcers with grey, yellow exudate, well demarcated, bordered and soft friable base, severe lymphadenopathy that may suppurate. The painless ones are caused by the Treponema pallidum or syphilis, single ulcer or chancre, regular borders and hard base, chlamydia trachomatis, serovars L1 to L3, lymphogranuloma venereum, small shallow ulcers often missed, and can progress to painful fluctuant adenitis or buboes. So this is a new table, the newer version of the same table that we just discussed. So herpes simplex virus lesions look something like this. So the diagnosis is viral culture or PCR, vesicles to ulcers. So initially they are vesicles, then become ulcers. So pustules, vesicles or small ulcers on erythematous base. Tender lymphadenopathy and systemic symptoms are common. Haemophilus ducrei or chancroid, large deep ulcers with grey yellow exudate, well demarcated borders and soft friable base, severe lymphadenopathy that may suppurate, draining lymphadenopathy. The painless ones are Treponema pallidum or syphilis, usually single ulcer, chancre, indurated border and hard non-purulent base. Chlamydia trachomatis serovars L1 to L3, lymphogranuloma venereum. Initial small shallow ulcers often missed, and then painful and fluctuant adenitis or buboes will ensue. Gonorrhea and chlamydia. The most common STI in women less than 25 years of age. Most commonly they are asymptomatic. All sexually active females less than 25 and women age more than 25 with risk factors like multiple sexual partners, inconsistent condom use are advised chlamydia trachomatis and Neisseria gonorrhea screening annually in addition to Pap testing. Chlamydia and gonorrhea in women. Risk factors are age less than 25, high risk sexual behavior. Manifestation is asymptomatic, most common. Cervicitis, urethritis, and perihepatitis, which is Fitz-Hugh-Curtis syndrome. Diagnosis is nucleic acid amplification testing. Treatment and very treatment is with azithromycin with ceftriaxone. Confirmed chlamydia with azithromycin and confirmed gonorrhea with azithromycin with ceftriaxone. Complications are pelvic inflammatory disease, ectopic pregnancy, infertility, and pharyngitis. Preterm birth prevention. Prior preterm delivery, if no, so second trimester transvaginal ultrasound for cervical length. If there is normal cervical length, do the routine care. If incidental short cervix less than 2.5 cm at less than 24 weeks, give vaginal progesterone. If there is a history of preterm delivery, then prior preterm delivery is associated with painful contractions. If no, then it is cervical insufficiency and we can give prophylactic circlage. If yes, then it is prior preterm labor and intramuscular 17-hydroxyprogesterone is given. Syphilis. Syphilitic changes from the site of direct inoculation of Treponema pallidum. Only single lesion forms at a time. They are extremely infectious. Most chancres resolve spontaneously within 6 to 8 weeks if untreated, but systemic spread results in continued infection. After exposure, that is 3 to 60 days, patient develop a single papule that turns into shallow, painless, non-exudative ulcer with indurated edges. Patients with strong evidence of primary syphilis with negative serology results should be treated empirically with IM benzathine penicillin G. In these patients, repeat non-treponemal serology should be done in 2 to 4 weeks to establish baseline. Four-fold increase at 6 to 12 months would confirm the adequate treatment. Syphilis diagnostic serology. Non-treponemal, that is RPR VDRL, antibody to cardiolipin, cholesterol, lecithin antigen, quantitative titers, possible negative results in early infection, decrease in titer confirms the treatment. Then treponemal investigation, that is FDA, ABS and TPEIA. FDA, ABS means fluorescent treponemal antibody testing, antibody absorption. RPR is rapid plasma region and TPEIA means treponemal pallidum enzyme immunoassay. So antibody to treponemal antigens, qualitative, reactive and non-reactive, greater sensitivity in early infection and positive even after treatment. Sexual assault. How do you evaluate that? Physical and forensic examination, for example, hair and semen, and psychological assessment, consequences, mental health disorders like PTSD, unintended pregnancy, and sexually transmitted infections, management, post-exposure prophylaxis, emergency contraception, and psychological counseling. Post-exposure prophylaxis and sexual assault. Chlamydia, give azithromycin. For gonorrhea, give ceftriaxone. Trichomonas vaginalis, metronidazole. HIV, multi-drug regimen, that is tenofovir, emtricitabine with raltegravir, and hepatitis B vaccine with or without hepatitis B immunoglobulin. UTI, urinary tract infections. The pathogenesis is E. coli most common, and it is E. coli ascends into the urethra because there is a close proximity between the urethra and the anus in the women. So it ascends upward into the urethra, causing ascending infection, and that infection can go into the kidneys as well. Clinical features are dysuria, urinary urgency and frequency, hematuria and suprapubic flank pain. Diagnosis is with pyuria, bacteriuria on the urine culture, and treatment is with antibiotics. Recurrent UTIs, recurrent cystitis in women. Definition: more than 2 infections in 6 months or more than 3 infections in a year. Risk factors are sexually active, post-menopausal, first UTI at age less than 15, and spermicide use. Okay, these women with these characteristics will have recurrent cystitis. Prevention is daily antibiotic prophylaxis and post-coital prophylaxis, that is antibiotics after sex. So abnormal uterine bleeding, defined as menstrual bleeding that is prolonged more than 5 days, heavy more than 1 pad every 2 hours, and irregular. Causes of abnormal menstrual bleeding are fibroids, adenomyosis, and endometrial cancer hyperplasia. Fibroids, the clinical features are heavy menses, constipation, urinary frequency and pelvic pain heaviness, and enlarged uterus. Adenomyosis, dysmenorrhea and pelvic pain, heavy menses, bulky globular and tender uterus. Endometrial cancer hyperplasia, history of obesity, nulliparity or chronic anovulation, irregular intermenstrual or post-menstrual bleeding, and non-tender uterus. Indications for some investigation. Firstly, breast MRI, only done in BRCA, not usually done. Patients with non-cancer to evaluate for recurrence. High-risk patient with BRCA carrier, first degree relative of non-BRCA carrier. Mammography, women age more than 30, less than 30, only MRI is done. For core biopsy, complex cyst, for example, echogenic debris, thick septa and solid components. If simple cyst mass recurs, if mass does not disappear after aspiration, then we have to do core biopsy. Endometrial biopsy, in cases of postmenopausal bleeding, abnormal uterine bleeding in the patient over age 45, abnormal uterine bleeding in the patients less than 45 who have failed medical management, that is no change in abnormal uterine bleeding even after taking OCPs, more than 6 months of abnormal uterine bleeding, obesity, tamoxifen therapy. Then thickened endometrial strip with ovarian mass of more than 4 millimeters on ultrasound. Endometrial cells on Pap test in a post-menopausal woman or a premenopausal woman with abnormal uterine bleeding or risk of endometrial hyperplasia. So these are indications of doing the endometrial biopsy. Then progesterone withdrawal test to evaluate secondary amenorrhea, no menses more than 6 months in the patients with previously irregular menses, to determine if the amenorrhea is from low estrogen levels, that is no bleeding after progesterone. Okay. Then undiagnosed abnormal uterine bleeding as contraindications. Undiagnosed abnormal uterine bleeding is contraindication to endometrial ablation because it can prevent evaluation of endometriosis in patients, and it can prevent the evaluation of endometrium in patients with possible endometrial hyperplasia or cancer. Undiagnosed abnormal uterine bleeding is a contraindications to hysterosalpingogram because the procedure could spread the cancerous endometrial cells into the abdomen. Patient with the abnormal genital tract development should be evaluated for associated renal abnormalities with renal ultrasound. Okay, then we have this progesterone withdrawal test. So high estrogen, endometrial thickness, progesterone administered, there will be withdrawal bleeding. Okay, in low estrogen, even after administration of progesterone, no withdrawal bleeding will occur. Okay, they were saying that to evaluate secondary amenorrhea, no menses more than 6 months in patient with previously irregular menses, to determine if amenorrhea is from low estrogen levels, that is, if it is from low estrogen levels, so there will be no bleeding after progesterone administration. So why is it called progesterone withdrawal test? Okay. Then clomiphene citrate, it is used to induce ovulation. It is an estrogen modulator that primarily blocks the estrogen receptors at the level of hypothalamus, inhibits negative feedback mechanism, restoration of pulsatile GnRH secretion by the hypothalamus. HCG, produced by syncytial trophoblast in early pregnancy for preserving corpus luteum in order to maintain the progesterone secretion until placenta starts making progesterone on its own. Production of HCG begins 8 days after fertilization and level doubles after every 48 hours until they peak at 6 to 8 weeks of gestation. Other functions are male sexual differentiation and maternal thyroid gland stimulation. Atypical glandular cells on Pap testing. If these cells are seen on Pap testing, one should move forward with investigation of ectocervix, endocervix, and endometrium. Tests for these investigations are ectocervix colposcopy, endocervical curettage, and for endometrium we do endometrial biopsy. Ovarian mass in the post-menopausal patient. Risk factors for ovarian cancer are age, fertility drugs, nulli gravidity, and BRCA mutations. CA125 is a biomarker for epithelial ovarian cancer. It's due to too many ovulatory cycles, repeated damage, and malignant transformation. It may be increased in other gynecological conditions, that is leiomyomata and endometriosis, but most importantly, it is a marker for epithelial ovarian cancer. But these conditions occur in premenopausal women, and this is happening in postmenopausal women. Hence, specificity of CA125 increases in postmenopausal women. Its level as measured in conjunction with pelvic ultrasonographic finding to categorize an ovarian mass likely, malignant, or benign. Management: pelvic ultrasound CA125 levels, periodic ultrasound. If mass has no malignant features on ultrasound, small size, simple cyst, and CA125 is normal. Further imaging, that is MRI and CT. If mass has suspicious features on ultrasound, that is large mass, solid components, septations, and if CA125 is high. Note: needle aspiration is contraindicated in postmenopausal women with adnexal mass due to risk of spreading potentially malignant cells should the mass prove cancerous. Epithelial ovarian carcinoma. Epithelial ovarian carcinoma refers to a malignancy involving ovary, fallopian tube, and peritoneum. Diagnosis is by exploratory laparotomy. Image guided biopsy is contraindicated as the mass may rupture and cause seeding of cancer cells in the abdominal cavity. Epithelial ovarian carcinoma. The clinical presentation is asymptomatic incidental adnexal mass, subacute pelvic abdominal pain, bloating, and early satiety. acute, there will be dyspnea, obstipation, constipation, and abdominal distension. Risk factors are family history, genetic mutations of BRCA1 and BRCA2, age more than 50, hormone replacement therapy, endometriosis, infertility, and early menarche and late menopause. Protective factors are oral contraceptive, multiparity, breastfeeding. Lab findings include increased CA125. Ultrasound findings include solid complex mass, thick septations, and ascites. Management includes surgical exploration with or without chemotherapy. Ovarian tumors and markers. For dysgerminoma, lactate dehydrogenase secreting germ cell tumor, so beta hCG and LDH level will be elevated. Granulosa cell tumor, it is a large complex ovarian mass with increased estrogen. So estradiol and inhibin will be elevated in the granulosa cell tumor. Granulosa is a girl with granny who like estrogen and calls Exner. So it was a sketchy mnemonic. Okay. So estradiol and inhibin will be elevated. Then yolk sac tumor, alpha fetoprotein, certainly lady tumor, androgen, testosterone, and androstenedione. So thecoma, estrogen, thecoma, E is for estrogen. Call Exner bodies, estrogen. Okay. So girl and granny estradiol inhibin. Y male alpha fetoprotein. Yolk sac, alpha fetoprotein, male something. Okay. Then certainly lady, certainly semen androgens. So that is vaginal dryness, dyspareunia, oligomenorrhea, all estrogen decrease symptoms, and breast atrophy. Certainly Leydig cell tumors, pathogenesis is sex cord stromal tumors and increased testosterone. The clinical features are rapid onset virilization, voice deepening, male pattern balding, increased muscle mass, clitoromegaly, oligomenorrhea, and unilateral solid adnexal mass. Classic symptoms are rapid onset virilization and signs of estrogen deficiency. Testosterone inhibits the GnRH, decreased LH, and decreased estrogen. Clitoris producing more clitoral hood, a classical virilization finding. Remember this. So the clitoral hypertrophy looks something like this. So this is clitoral hood. Large clitoris has many size and shape variations. Okay. So this is urethra, skin glands, vestibule, Bartholin glands, and posterior foreshape of the vagina. This is vaginal entrance, labia majora, and labia minora. So aromatase deficiency. Cortisol inhibits the ADH for some reason. Okay. Then DHEAS adrenal, DHEA dihydroepiandrosterone, adrenal, and DHEA is ovarian. What is the difference between both of these things? Okay, important to distinguish from adrenal and ovarian. Okay, so aromatase deficiency, dihydroepiandrosterone, it is converted into androstenedione, and androstenedione with aromatase in the adipose tissue is converted to estrone. In the peripheral tissue, it is converted to testosterone, and testosterone via aromatase in ovary will be converted into estradiol. And we know this pathway that is, happening in the adrenal glands. The cholesterol is converted to pregnenolone, which is converted by 17 alpha hydroxylase into 17 hydroxypregnenolone, that is converted into dehydroxyepiandrosterone. So pregnenolone will be converted to progesterone. 21 hydroxylase will convert this thing into 11 deoxycorticosterone, which is a weak mineralocorticoid. 11 beta hydroxylase will convert this into corticosterone, weak glucocorticoid, and aldosterone. So this thing is happening in zona glomerulosa. This is happening in zona fasciculata, in which pregnenolone will be converted into 17 hydroxypregnenolone, and progesterone via 17 alpha hydroxylase is converted into 17 hydroxyprogesterone. Then 17 hydroxyprogesterone by the same enzyme 21 hydroxylase is converted into 11 deoxycortisol, and this by the same enzyme 11 beta hydroxylase is converted into cortisol. And this is zona radicularis. Okay, I could not understand this thing. So deficiency of enzyme aromatase, which converts androstenedione and testosterone to estrone and estradiol respectively. Features are normal internal genitalia. External virilization, we're talking about aromatase deficiency. Okay, so internal genitalia will be fine. The external virilization will occur. Undetectable serum estrogen levels. Your deficiency of what? Aromatase. So aromatase converts testosterone into estradiol, and androstenedione into estrone. So if aromatase is not there, so there will be no estrogen detectable. Transient masculinization of mother that resolves after delivery. Adolescent symptoms: delayed puberty, osteoporosis because of absence of estrogen, undetectable serum estrogen levels, no breast development, and high concentration of gonadotropin that result in polycystic ovaries. The primary ovarian androgens are testosterone, androstenedione, and dehydroepiandrosterone (DHEA). These are ovarian androgens. The adrenals also produce these androgens as well as DHEA sulfate. So if it has a sulfate with it, it is from the uh, adrenals, and if it is just dehydroepiandrosterone, it is ovarian in origin. Okay. Therefore, women with a suspected androgen producing tumor should be evaluated with serum testosterone and DHEAS levels. Elevated testosterone level with normal DHEAS level suggest an ovarian source, more common, and elevated DHEAS level suggest an adrenal tumor, far less common. Okay, so ovarian source is more common. In Sertoli Leydig tumors, Sertoli Leydig cell tumor, the pathogenesis is sex cord stromal tumor, and there is increased testosterone with Sertoli Leydig cell tumors. The clinical features are rapid onset virilization with voice deepening, male pattern balding, increased muscle mass, clitoromegaly, oligomenorrhea, unilateral solid adnexal mass, and management with surgery and tumor staging. A type of sex cord stromal tumors of the ovaries secretes high testosterone level. Consider high suspicions of androgenic secretion tumor if there is virilization, rapid onset less than 1 year hyperandrogenism. Symptoms due to testosterone excess are hirsutism, that is, there will be excessive hair growth, virilization with male pattern baldness, for example, temporal hair loss, increased muscle bulk, clitoromegaly, and voice deepening. Due to estrogen deficiency, testosterone inhibits the GnRH and pituitary FSH-LH release, breast atrophy, vulvovaginal atrophy, dyspareunia, and oligomenorrhea. Diagnosis is with the patients with virilization require evaluation of the tumor to be distinguished between ovarian and adrenal sources of androgen production with total testosterone, 17-hydroxyprogesterone, and DHEAS. Ovarian androgen secreting tumors produce markedly elevated testosterone levels, that is more than 150 nanogram per deciliter. Adrenal tumors produce markedly elevated DHEAS level, dihydroepiandrosterone sulfate, more than 700 millicentigram per deciliter, and pelvic ultrasound. Differentials include adrenocortical carcinomas, aromatase deficiency, and PCOS. Differentiating points are increased DHEAS. For in adrenocortical carcinoma, there will be increased DHEAS. In aromatase deficiency as well, there will be increased DHEAS. For the PCOS, they will rarely cause virilization and mildly elevated testosterone. Causes of hirsutism in women: polycystic ovarian syndrome, oligomenorrhea, hyperandrogenism, and obesity. Associated with type 2 diabetes, dyslipidemia, and hypertension. Idiopathic hirsutism, normal menstruation and normal serum androgens. Non-classic 21 hydroxylase deficiency, similar to polycystic ovarian syndrome, elevated serum 17-hydroxyprogesterone. It appears in adolescence and it's mild, and classic in early, and there is full blown, it is mild one. Okay, so in PCOS, 17-hydroxyprogesterone level will not be elevated, which will be seen in the non-classic 21 hydroxylase deficiency. Androgen secreting ovarian tumors or ovarian hypertrichosis, more common in postmenopausal women. Rapidly progressive hirsutism with virilization and very high serum androgens. Cushing syndrome, obesity, usually of the face, neck, trunk, and abdomen, increased libido, virilization, and irregular menses. The primary ovarian androgens are testosterone, androstenedione, and dehydroepiandrosterone (DHEA). The adrenals also produce these androgens as well as DHEA sulfate. Therefore, Women with suspected androgen producing tumor should be evaluated with serum testosterone and DHEAS level. So we have read this before, but it is important. So elevated testosterone level with normal DHEAS level suggests ovarian source, and it is more common. Elevated DHEAS level suggests an adrenal tumor, which is far less common. Hyperandrogenism. The clinical features are hirsutism, nodulocystic acne, androgenic alopecia, and increased serum testosterone. Okay. Differential diagnosis is polycystic ovarian syndrome, androgen secreting tumor, Cushing syndrome, and non-classic congenital adrenal hyperplasia. This is nodulocystic acne. This is also nodulocystic acne. Here you can see scarring and nodules and cysts. Okay, I think this is a nodule and this is a cyst. Okay, management of suspected ectopic pregnancy. An intrauterine pregnancy may be seen with transvaginal ultrasonography at a beta hCG level of 1500 to 2000 international units per liter. An intermediate pregnancy on transvaginal ultrasonography should undergo beta hCG level testing. If beta hCG level is less than 1500, repeat beta hCG in 2 days. It doubles every 48 hours. If beta hCG level is more than 1500, do transvaginal ultrasonography again. Management of suspected ectopic pregnancy. Positive urine hCG, lower abdominal pain or vaginal bleeding. So look if the woman is hemodynamically stable or unstable. If she is unstable, immediate surgical consultation is done. If she is hemodynamically stable, dynamically stable, transvaginal ultrasonographic scan is done. If there is an adnexal mass, treat the ectopic pregnancy. It can be an intrauterine pregnancy as well. If it is non-diagnostic, serum beta hCG level is done. More than 1500 international units per liter, repeat beta hCG level with transvaginal ultrasonography in 2 days. If it is less than 1500 international units per liter, repeat beta hCG level in 2 days. Then we have human papillomavirus. So HPV infection and progression to cervical cancer. This is normal cervix. When HPV particles start invading, they move from below upwards, right? So low grade is less than 1/3 epithelium involved, this one. High grade is more than 1/3 epithelium involved. These are cervical intraepithelial lesions or neoplasia, which is basically dysplasia. And then we have cervical carcinoma, in which there is microinvasive or invasive past basement membrane. Once they move upward, then they start moving downward and they cross the basement membrane. This is squamous epithelium. Then we have the basal layer, the basement membrane, which is invaded over here. Vaccination. Routine vaccination in women start at age 11 to 12. Catch-up vaccination should be offered until age 26 for the patients who are unvaccinated or did not complete the series. Treatment of condylomata acuminata. Cryotherapy, that is with liquid nitrogen. Then topical imiquimod and trichloroacetic acid. Human papillomavirus. Associated diseases are cervical cancer, vulvar and vaginal cancers, anal cancer, penile cancer, oropharyngeal cancer, and genital warts. Vaccine indication are all girl and women aged 11 to 26, boys and men aged 9 to 21, that is 9 to 26 for men who have sex with men, and individual with HIV, including those with history of genital warts, abnormal cytology, or positive human papillomavirus DNA test. Then condylomata acuminata, accumulated like cauliflower. Etiology is HPV 6 and 11. The clinical features are multiple pink or skin colored lesions, lesions ranging from smooth flattened papules to exophytic cauliflower-like growths. Treatment. Chemical podophyllin resin, that is trichloroacetic acid, chemically injures it. Immunologic, that is imiquimod. Immune response to it, and surgical is with cryotherapy, laser therapy, and excision. Prevention is with vaccination and carrier contraception. So this is a picture of condylomata acuminata. Then what is a PAP test? It begins every 3 years at age 21 in immunocompetent patients regardless of age of onset of sexual activity or the number of sexual partners. Routine HPV testing in women aged less than 30 is done because infection mostly clears away and does not progress to cervical dysplasia. Routine HPV testing otherwise can lead to unnecessary cervical procedures leading to pregnancy complications. At age more than 30, PAP test with HPV co-testing may be done and repeat every 5 years. If negative or only PAP test is done every 3 years. Normal pap test excludes persistent HPV infection. Patients with adequate screening by age 65 can stop undergoing pap test. If a patient has a history of CIN2 or higher on histology, screening should continue for another 20 years. Do not terminate pap test at age 65 for the patient with risk factor cervical cancer, that is immunosuppression, tobacco use, and diethylstilbestrol exposure. When to stop pap testing? Age 65 or hysterectomy, plus no history of cervical intraepithelial neoplasia 2 or higher, and 3 consecutive negative pap tests or 2 consecutive negative co-testing results. PAPs may requiring endometrial sampling. So results are benign appearing endometrial cells. Group requiring endometrial sampling are in premenopausal women with abnormal uterine bleeding and risk for endometrial hyperplasia, and postmenopausal women. Atypical glandular cells, women aged more than 35 at risk of endometrial hyperplasia, and atypical glandular cells favor neoplastic, all women. Okay, what is HELP syndrome? HELP syndrome is hemolysis, elevated liver enzymes, and low platelet syndrome. So features are hemolysis, increased liver enzyme and decreased platelets. Pathophysiology includes abnormal presentation, triggering systemic inflammation, leads to activation of coagulation system and complement cascade. Platelets are rapidly consumed, that is thrombocytopenia. Resulting thrombosis in portal system leads to hepatocellular necrosis and increased liver enzymes. Management first of all stabilize the patient with antihypertensive drugs and or magnesium sulfate. Afterward, delivery is the only definitive treatment in HELP syndrome. Indication for delivery are more than 34 weeks of gestation, any gestational age with abnormal fetal testings or severe worsening of the maternal status. So HELP syndrome, the clinical features are preeclampsia, nausea and vomiting, right upper quadrant abdominal pain, lab findings of microangiopathic hemolytic anemia, elevated liver enzymes and low platelet count, and treatment is delivery, magnesium for seizure prophylaxis and antihypertensive drugs. Okay. Then lactational amenorrhea. Amenorrhea due to increased prolactin in a lactating mother. Increased prolactin inhibits the GnRH production. It provides natural contraception for the first 6 months. After 6 months, more than 50% of the women resume ovulation and require another form of contraception. Got it. Then we have HPO axis. So hypothalamic pituitary ovarian axis. Hypothalamus, it stimulates the release of GnRH. Hypothalamus releases GnRH on the anterior pituitary to stimulate the release of FSH and LH, which will go and act on the ovary, and there will be ovulation, and follicles will start releasing estrogen, inhibin and progesterone. The inhibin and progesterone will have a negative feedback impact on the anterior pituitary to stop the production of LH and FSH. Also, estrogen has a negative feedback. Okay, so the inhibin, I don't know. Okay, estrogen, inhibin, and progesterone have a negative feedback loop on the anterior pituitary and hypothalamus to stop the secretion of GnRH and FSH and LH. Inhibitory, except during mid-cycle. Yeah, during mid-cycle, the estrogen surge is responsible for during mid-cycle. It is not inhibitory, right? During mid-cycle, there is an LH surge because of excessive estrogen. Yeah, otherwise it is inhibitory. Okay. Then we have normal pubertal growth in girls. So this is the growth velocity. Peak height velocity, and this is menarche and breast development. So age years. So growth starts, there's a growth spurt in the girls from age of about 10 years to 12 years, and there is a peak height velocity, and then the growth velocity reduces all the way down till 15 years, and then it does not, then they don't go any further. The Tanner stages are Tanner stage 1 less than 10 years, Tanner stage 2 is age 10 to 11.5 years, Tanner stage 3 is 11.5 to 13 years, Tanner stage 4 is 13 to 15 years, and Tanner stage 5 is more than 15 years. So these are different stages of Tanner. Like in Tanner stage 1, there is thelarchy but no pubarchy. The breast enlarges and there is pubarchy starts occurring, then the breast size grows further, and pubic hair also start growing, and this is stage 5 where complete development of breast and pubic hair has occurred. Primary dysmenorrhea. Primary dysmenorrhea is at onset of menarche. Adolescents have irregular hypothalamic pituitary ovarian axis. There is no ovulation in the beginning. As this excess ovulation can cause excessive prostaglandin release during menses, which results in crampy bilateral lower abdominal pain that may radiate to back and thighs, nausea, vomiting, and diarrhea, and fatigue and dizziness. Primary dysmenorrhea is common in up to 90% adolescents. Features starts 1 to 2 days before the onset of menses, resolves a few days after the onset of menses. Patients also have associated malaise and dizziness. GIT symptoms due to the prostaglandin-induced stimulation of GIT includes nausea, vomiting, and diarrhea. Normal pelvic examination, no pain after menses ends, and gets better as the patient ages. Risk factors are age less than 30, BMI less than 20 kg per meter square, tobacco use, menarche at age less than 12, heavy long menstrual periods, and sexual abuse. Treatment is NSAIDs. In non-sexually active patients, NSAID inhibit the prostaglandin synthesis. Combination oral contraceptive pills in sexually active patients who also want contraception thins endometrial lining, reduces prostaglandin release, and decreases uterine contractions. Do not use other contraceptions like intrauterine devices increase the pain symptoms with its inflammatory reaction in the uterus. Medroxyprogesterone increase body fat, decrease lean muscle mass, and increase the risk of loss of bone mineral density. Then we have differentials. Differentials of what? Dysmenorrhea. Okay, so adenomyosis. For that, there must be age more than 40. Symmetrically enlarged globular uterus. Endometriosis. Pain persists throughout the menses and there will be immobile uterus. Mittelschmerz. Mid-cycle pains. Pain occur approximately 2 weeks prior to the menses. And pelvic congestion syndrome. Dull, ill-defined pelvic ache that worsens with the intercourse or during long periods of standing. Pain prior to menses that is then relieved by menses. Okay, so primary dysmenorrhea. Etiology is excessive prostaglandin production. Age less than 30, BMI less than 20 kg per meter square, tobacco use, menarche at age less than 12, heavy long menstrual period, and sexual abuse. The clinical features are pain first 2 to 3 days of menses, nausea, vomiting, and diarrhea, and normal pelvic examination. Management is with non-steroidal anti-inflammatory drugs and combination oral contraceptives. Okay, then secondary dysmenorrhea. It is a pathological cause of painful menses. Patients with any of the following clinical features should be evaluated for secondary causes of dysmenorrhea. Symptom onset age more than 25, unilateral non-midline pelvic pain, no systemic symptoms, and abnormal uterine bleeding. Pelvic organ prolapse. So definition is bowel, bladder, or uterus herniation into vagina. The clinical features are asymptomatic, like incidental finding, vaginal pelvic pressure, stress urinary incontinence and retention, constipation and incomplete defecation. Management is, if it is asymptomatic, do the observation. If it is symptomatic, pelvic floor muscle Kegel exercises, vaginal pessary and surgical repair. Uterine procedentia, a form of pelvic organ prolapse. It occurs due to weakened pelvic support and increased intra-abdominal pressure. Symptoms are vaginal pressure, bulging mass that increases with Valsalva maneuver. Pelvic organ prolapse is often asymptomatic and does not require treatment. However, if patient develops symptoms, a few are written below, then treatment is indicated. For example, if there is pelvic pressure or bowel or bladder dysfunction, or if there is sexual dysfunction and tissue damage, for example, erosion. Then pelvic organ prolapse definitions. If bladder is prolapsing, it is called as cystocele. If rectum prolapses, it is rectocele. If small intestine, so it is enterocele. Procedentia, what is that? I don't know. Apical prolapse, uterus and vaginal vault. Then risk factors are obesity, multiparity, hysterectomy, post-menopausal age. Uterine procedentia means a form of pelvic organ prolapse. It occurs, so basically like uterus is herniating downwards. Okay. Then clinical risk factor is also post-menopausal age. The clinical features are pelvic pressure, obstructed voiding, urinary retention, urinary incontinence, constipation, fecal urgency and incontinence, and sexual dysfunction. Management is weight loss, pelvic floor exercise, vaginal pessary, and surgical repair. So there are different types of pessaries which can be placed. These are incontinence dish without support, ring without support. This is a cube. Then we have Smith. This is gel horn and Hodge pessary. So pessary is placed something like this. This is vagina and uterus and something. Okay. Then premenstrual syndrome. Recurrent physical and affective which are mood symptoms that generally occur 1 to 2 weeks before the onset of menstruation and ends with the onset of menses for or a few days thereafter. Evaluation should include a symptom diary over 2 menstrual cycles, and it should show recurrence of symptoms during the luteal phase 1 to 2 weeks before menses, resolution of symptoms during the follicular phase, onset of menses or a few days thereafter. To make the diagnosis, the symptoms should reach a point of socio-economic impact. Treatment is SSRIs and oral contraceptive pills. They are contraindicated in patients with migraines. So post-menstrual syndrome or premenstrual syndrome or premenstrual dystrophic disorder. Clinical features occurring during the luteal phase are physical, bloating, fatigue, headache, hot flashes and breast tenderness. Behavioral changes are anxiety, irritability, mood swings and decreased interest. Evaluation, symptom and menstrual diary, and treatment is with SSRIs. Okay, then we have granulosa cell tumor. Normally, granulosa cells have following functions: convert testosterone to estradiol via aromatase and secrete inhibin. Tumors of these cells lead to overproduction of estradiol and inhibin. Chronic and unopposed estrogen exposure can lead to endometrial hyperplasia and cancer, for example, post-menopausal bleeding. Evaluation is endometrial biopsy, surgical staging. After surgical management, inhibin level can be monitored to evaluate for disease progression or recurrence. Treatment: no associated endometrial cancer. Unilateral salpingo-oophorectomy preserves fertility. Associated endometrial cancer, bilateral salpingo-oophorectomy and hysterectomy. Note: endometrial ablation is contraindicated in endometrial cancer. Differentiations of differentiations of granulosa cell tumor are Brenner tumor. Differentiating points are rare benign subtype of epithelial ovarian tumor found incidentally, no association with endometrial hyperplasia. Embryonal carcinoma occurs in young women, secretes alpha fetoprotein and beta HCG, no association with endometrial hyperplasia. Mature teratoma occurs in young women aged 10 to 30, and yolk sac tumor occurs in young women, secrete alpha fetoprotein, and there is no abnormal uterine bleeding. Okay. So I think we should keep this session till here, and then we'll continue from the granulosa cell tumor table in the next session. Until then, Allah Hafiz, fi Amanillah, and take care.